Patients, we are going to allow everyone to join us. We apologize for the 5-minute delay, but we are live and welcome to the multidisciplinary approach on chronic conditions in primary care from spring to summer. My name is Nicole Barrera, and I will be your moderator. Before we start, I would like to let you know that we do have interpretation services, simultaneous interpretation services, and you may go to menu, then you are going to see interpretation. You should select more, and then you can select the language that you prefer. I also wanted to let you know that this is an initiative from the PRST, which is a program for the Science, Technology, and Research Trust. And the purpose of this series is to connect specialists with academic medical centers and providers for primary care for physician in rural areas. You may turn your camera. We would like to see you, and you can type on the chat during any time of the presentation. You may open your microphone if you have any questions, and this webinar is going to be recorded with educational purposes. So we're going to start with the topic for today, which is updates in the management of dyslipidemias and the new guidelines of 2026 for primary care. And we have Dr. Carla Colón, cardiologist. Welcome, Carla. And please go ahead. Thank you very much. Good afternoon, everyone. And we're going to have a crash course on the new guidelines for cholesterol management. And it's important that these guidelines are replacing the old guidelines from 2018. And one of the things that we see more is triglycerides management, and they are incorporating lipoprotein A, this additional indicator for cardiovascular risk. And we're going to talk more about that. Several of the objectives that we have today for these approximately 30 minutes, we're going to start with to identify the cholesterol molecules which are important. Usually we pay attention to LDL, but we have additional molecules like these other molecules that are atherogenic. We have apolipoprotein B and now LPA. We are going to stratify our patients' risk with more modern guidelines, and we use a different calculator, which is PREVENT. We're going to see other risk enhancers, and I apologize, I am using Spanglish, and the task force, which is an additional study, some imaging in some patients when we still have some questions. We are going to verify how we're going to treat our patients, both with total LDL-C reduction and also to escalate therapy and safely. So what is completely new in these new 2026 guidelines? Because some things are going to change. And the first thing is the PREVENT score. Before, we use a quantitative equation, and you would do the computation, and you would see the risk for 10 years. But now you can see the risk for 10 years and for 30 years. And not only that, you can calculate it since the patient is 30 years old. Before, they had to be 40 years old. Even though you had a high number for cholesterol, it wouldn't allow you to calculate it. And on red, we see the LDL goals, but now they are a little bit more strict, and they are adapting to the European guidelines. On purple, we can see the lipoprotein A. Now we need to measure for everyone, even if it is once in their lifetime. We need to measure it, and this is an additional cardiovascular risk or an enhancer. On orange, we can see the CAC score. Now it has a larger role in these guidelines in management, for example, additional stratification. And in general terms, we start verifying it earlier in the patient, and we start treating earlier. We are not going to wait to have an event to do something about it. there are some definitions that I think that when we talk to the patients, it is easier to understand them. For example, on red, we can see what is ASCVD, uh, arteriosclerosis, cardiovascular disease. And when we think about infarcts, but no, it is any coronary event. It may be unstable angina. Now it is an ASCVD, the ACS-MI angina. Revascularization in the coronaries or any arteries on the body. It may be cardiac, legs, renal, stroke, or TIA or PAD. On blue, we have dyslipidemia. Before, we always said elevated cholesterol, but triglycerides elevated is also dyslipidemia, and now an elevated LPA is also considered dyslipidemia. And there is an ICD-10 for lipo LPA. So this is a separate condition. On green, and they mention it as subclinical atherosclerosis. It's really important because I think that the previous guidelines for cholesterol, this was not covered. We wouldn't know what to do with this, but you may have a CAC score with a high number, and you know that you need to treat that patient as if they already had this coronary disease. Or, for example, more common in your practice, the patient may have symptoms of pneumonia or cough that doesn't make sense, and we do a CT scan, and all of a sudden, they have coronary disease, and they say arteriosclerosis, calcifications in the blood vessels. Well, that patient, even though they don't have any symptoms, they already have coronary disease. So this is subclinical atherosclerosis, and it needs to be treated. And lastly, we have the very high risk ASCVD. They are at a very high risk. And it has its own classifications and definitions. And it's two major events of ASCVD or one major event plus two high risk features. And I added a new slide for you to have access to this information because I think that if we take a look, these patients with ASCVD, most of them are already very high. The major ASCVD events. First, an ACS in the past year, a history of MI. You may have a patient at your clinic today that they had an ACS 10 years ago, and 2 months ago they had another, so they are at high risk regardless. A history of ischemic stroke in the past, or symptomatic PAD with claudication or with any ulcer that is not healing well. Uh, Also high risk conditions, 65 years or older, a bypass, a current smoker, with diabetes, a history of CHF. It is not specified in the guidelines if it is with preserved or reduced force, only CHF. Hypertension and LDL over 100, despite the maximum statin and ezetimibe, they are already at very high risk. So most of the patients that you're going to see at your clinic that had any event, they are going to comply with this criteria. For example, a 65-year-old man with hypertension and diabetes who had a heart attack, or you found a cholesterol plates in their legs. This patient is already very high risk. And it is important to recognize this because they are going to need more intensification in their therapy. Next. So here you can see like a 5-step approach on how to manage these patients at the office. What are the 5 steps to take? First, we are going to confirm that the patient has high cholesterol. The specific, the guide specified, and we're going to see what we see in the practice versus what the guidelines say. The guidelines say that there is no more difference. It could be acceptable having a lipid profile, that the patient is not fasting. But if the triglycerides are over 150, you're going to review it in fasting. So order the lipid profile in fasting, so you measure only once. Particularly if the triglycerides are high, you need to double check. Second, we need to look at secondary causes. For example, you're going to have many young ladies in a medication with Accutane for acne, and this increases the cholesterol terribly. And maybe it's just the medication, the acne medication. Family history with premature ASCVD in the family, that's really important. Another important thing is if they are planning a pregnancy, yes or no, because most of the patients, and right now I have many patients at the office. I have a patient that she has 180 bad cholesterol, but she's in a procedure for fertilization, trying to get pregnant. So I cannot put her on a statin because it is contraindicated for pregnancy. So it's important to keep this in mind. We need to measure the LPA for everyone at least once in their lifetime. Sometimes we need to fight with the medical insurance because they don't want to cover it. And the ApoB is not indicated for everyone, but some patients are going to require it. For example, a diabetic patient with cardiac failure and the LDL seems to be fine, but you're suspecting that they're higher cardiovascular risk, you need to measure it again, the ApoB. It's an additional marker. The guides talk about the CKM, chronic kidney metabolic disease. They specified, and it's important to keep in mind that this is like a metabolic syndrome. This patient who is obese, high blood pressure, fatty liver, but they also have a kidney failure. So they have an increased cardiovascular disease, and we need to identify it. We are going to classify them because we're going to see how we're going to treat the patient. If they have previous cardiovascular events, so these are the cholesterol goals. If LDL is over 190, those are additional cholesterol goals, and we prescribe the medication. It doesn't matter how much is at risk. If they don't have any of the previous one, definitely we're going to calculate the risk, and we are going to act based on that. And planning, we are going to recommend everyone a change in their lifestyle, eh, everyone, and we're going to see what are those additional goals that we need to have for LDL and non-HDL. Which lipid markers answers which question? LDL-C is the one we pay the attention mostly at the clinics. We follow this metric. They have very established goals. So this is a molecule that is very atherogenic. The non-HDL, I love that in these guidelines they mention it because it's something that intuitively we know it, but sometimes we don't know how to practice it. So it is important because from all your total cholesterol, you need to deduct the good cholesterol, and everything else is bad cholesterol. So this is important. And it's important, particularly in patients with high triglycerides. If they are over 150, since LDL is calculated, sometimes you have a number that is falsely low. So if you have a patient with triglycerides that are high, your goals should be based in the non-HDL. The ApoB is really important because this it carries all the particles, the atherogenic particles. So you may have an LDL, which is completely normal, but an ApoB very high, and you know that you need to be more aggressive because that ApoB is carrying these particles, which are going to become eventually in bad cholesterol. And LPA, as similar to LDL, we know that it is very atherogenic, maybe even more, in fact, but it is hereditary. So it is not that you're eating bad or you're misbehaving, that you're not exercising. You were born with that cardiovascular risk. And it is measured only once in a lifetime. It is considered to be a cardiovascular risk enhancer if the patient has that number that is high. Definitely, we need to measure in the rest of the family, particularly if they have children and siblings. And as I mentioned before, again, if you suspect that your patient has a lot of risk, diabetes, uh, kidney failure, high triglycerides, if that LDL is normal, but you are still concerned, then you should order LPA because it could escalate. It may be high. And we are going to talk about LPA. It is a number that it is not binary, it is not high or normal, it is non-binary. It is a number that the highest, uh, the highest your risk of having cardiovascular for a stroke and diseases in the arteries of your legs, and it is associated with uh, aortic stenosis because this is a sclerosis. So basically, they share this risk. Below 75, it's fantastic. It is a relatively normal number. 75 to 124, the risk is 1.2 times compared to the population. And today I saw a patient with 375. Obviously, we were alarmed, and she's 24 years old. So this is a patient that we know she has a very high risk, but it is not still contemplated in the guidelines what we are going to do with her, particularly because she is in her reproductive age. In this patient, for example, the most important thing is to lower cholesterol. So she's going to see the nutritionist. We're going to try to lower bad cholesterol in a more normal way or a more natural way, and to manage risk factors that we can control. The blood pressures must be perfect, the sugar must be perfect, and that patient should have a good Mediterranean diet, and they should be exercising. Things that we cannot promise the patients. I cannot tell them we're going to do a lot of exercise and diet, so the lipoprotein is going too low because the density of the molecule is going to stay the same, that concentration. So what you manage are other risk factors, the molecule is going to stay exactly the same. And there is no treatment for this yet. And still, things we need to do, if it is high, we need to make sure how is the children and the siblings of this patient to identify the risk, particularly if they have any events in the past. So we are going to see one of the most important parts because the bulk of the patients that you see in your office probably is this kind of patients. And here is how we're going to identify these patients to stratify their risk if they are from 30 to 79 years old and the cholesterol is like in a gray line between 70 and 189, it is not yet a severe hypercholesteremia. They don't have any cardiovascular events, and you don't have evidence of any plates because of any imaging study that they have been done. And so we go to the calculator, we input all the information, and I love the new calculator because it includes and many more things that we were not considering them before, like kidney function, weight, etc. And if the risk is less than 3%, it will be like everyone, good nutrition, a lot of exercise, and we are going to reevaluate it later. If the patient is below 3% for cardiovascular risk, but their LDL is between 160 and 189, which is substantially high, and their 30-year risk is more than 10%, you may consider starting the medication now, even though it is less than 3%. In people, when we are not going to have any question, is 3% and over. We are talking about medication. 3 to 5%. We need to find other risk enhancers. Uh, For example, lipoprotein A is one of the things that is going to help us. Maybe your patient has borderline risk from 3 to 5, but if they have the high lipoprotein, you're not going to wait for an event. you need to prescribe the statin. For example, if it's a woman who had preeclampsia, and it is a risk enhancer, a significant risk enhancer, a smoker, of course, we're going to prescribe. If it is intermediate, 5 to less than 10, definitely that patient, we need to prescribe a statin, at least moderate intensity. If the CV risk is closer to 10%, or you had other risk enhancers, we are going to consider a high intensity. And over 10%, it is a high intensity statin. You're going to treat that patient as if they already had the disease because they are at very high risk. I included a list of the risk enhancers because the guidelines mention them as if it is for dummies, but I think it is important to learn what is this, and they apply to our patients. History, family history, and it is in parents, siblings that had an ASCVD before 55 for men and 65 for women. If they are patients from, say, South Asia, Philippines, they have a higher severe risk, so they are considered the risk enhancers. Chronic inflammatory diseases, patients with lupus, psoriasis, arthritis. I have many patients with their arthritis disease is very aggressive, so they are considered risk enhancers. LPA, as I mentioned before, it is a risk enhancer. The high sensitive CRP, the previous guidelines from 2008 mentioned them, but in a very small print. But it is a risk enhancer. If you have any questions, you may order it. And it is an inflammatory marker, but atherosclerotic diseases are pro-inflammatory. So all inflammatory conditions, CKD, all of these increase the risk. Triglyceride over 150 if fasting, or over 175. Chronic kidney metabolic syndrome that we mentioned before, this constellation of many things together that increase the cardiovascular risk, and LDL persistently over 160, the reproductive history. And I think that in the history of all women, they should record how many pregnancies, if you had premature deliveries before 37 weeks, uh, gestational diabetes, gestational hypertension, premature menopause. So this is a very important risk factor, and it should be documented in all female patients. The guidelines propose this model on how we're going to manage the patient, and I like it because it is CPR, calculate, personalize, and reclassify. And CPR, no one is going to forget about those letters, CPR. First, calculate. We're going to calculate the 10-year prevent risk. It's calculated at 10 years and at 30 years. We are going to personalize. That's when we take into consideration all the history, the background of the patient, the reproductive history, family history, smoking, how are the other ancillary values that we consider, and reclassify. If the patient is still like a borderline that you are uncertain, the patient maybe is not certain of taking the medication or not, you may decide to use the CAC score. But it is important for you to know that this is an additional tool that you use. It should not be used as screening for everyone, because all the tests are done with a pretest probability. So this gives you certain information for you to do something about it. If not, we would all be running around like a headless chicken. Because honestly, you're going to see there and you're going to get scared. So a smoker patient, I don't measure the CAC score because all smokers have problems with the arteries. So diabetic patients over 40 years, uh, they will require statin, so I am not going to do the CAC score. And if they have an excessive high risk, I am not going to order send the test because we're going to get crazy with the results. So this is really important. And I wouldn't order a CAC score. And if the CAC score gets to you in the next slide, I am going to include it table of what are going to do with those values. If it is zero, fantastic. That patient, we don't need to prescribe statin for now. They need to change their lifestyle, and we're going to do it again, the CAP score in 3 to 7 years, unless we have any changes. If that CAC score is from 1 to 99, then that patient should be starting a moderate intensity statin together with significant changes in lifestyle, but their LDL goal is below 100. Also, I included the non-HDL values because that is going to help you if the triglycerides are high. If they are from 100 to 299, we need to treat that patient as if they had coronary disease, and we need to prescribe a first line statin, and the LDL it must be below 70. From 300 to 999, definitely you have a high amount of cholesterol plates in your heart. We need to intensify the therapy. They need to lose approximately 50% of the LDL for a goal of below 70. If they have even more severe risk, you may opt to treat them with less than 55, that LDL. And a CAT score over 1,000, definitely they have a significantly high risk of disease, so you're going to treat them as if they had already an event. And the LDL should be below 55, and this is a subclinical risk. Maybe they don't have a symptoms, they have not told you anything, but they have a lot of disease. On the bottom, I mentioned that if you find that a patient has cholesterol place on a CT scan that they have done of their chest for another reason, you treat them as if they had the disease. LDL below 70. If you review the previous tables and they are very high risk, definitely we need to have below 55, that LDL. And here, basically, we have a summary of groups. And this table, you may have it next to you on your desk at your office, and it is going to be very helpful. In these patients, I am working on primary prevention, and I don't want them to have any kind of events, and their risk is borderline uh, or intermediate. That LDL should be below 100. So we're going to reduce 30 to 49% and the non-HDL-C below 130. For patients who are working on primary prevention and they have a higher risk, and you are concerned because of the CKD or diabetic hypertension, with those patients, you need to be more aggressive and you're going to reduce the LDL below 70. Diabetic with many risk factors, like they already have failure, retinopathy, they need to be very aggressive and they need to lower LDL below 70.
For patients that have ASCVD but are not at very high risk, which are the tables that I already showed you in the at the beginning, if they are not a very high risk, you are going to lower it to 70. If it's a patient that is at high, very high risk, or they have cholesterol primary severe, you have to lower it less than 55. And as I mentioned before, most of the patients that have had a cardiovascular event already are high risk and should be looked at that way. Most of them, if they tell me I had a heart attack, they get to my office and they said I had a few months ago a heart attack, and I actually have a patient that had a STEMI with cholesterol plaques, 36 years old, and I am using a treatment as very high risk, even though it's just an event, because I don't know. Maybe there are things that I haven't been able to discover in that patient. So how are we going to use this little guide for medication. The first line of treatment, aside from lifestyle changes, which we're supposed to recommend for everyone, are statins. I don't know if the story is the same for you as for me, that everybody wants to avoid statins. I think that my day-to-day is convince them that this is a secure, safe medication. But yes, this is the first medication, first order medication. There's a lot of scientific evidence that it lowers mobility and mortality in cardiovascular diseases. It does not increase dementia risks. Or in terms of diabetes, we've studied statins and placebo, and patients that are using placebo develop diabetes 3 months after the ones that were using statin. So that should let you know that patients where you that you start with statin are already at a high risk of diabetes. It has nothing to do with the statin. It's because they already had that risk factor. Number two, ezetimibe. It's simple. It doesn't really lower cholesterol, but when you mix it with a statin, it empowers the effect and it lowers cholesterol. PCSK9, which is an inhibitor, it's a monoclonal antibody. It's very potent. We have to fight with insurance companies, but this is something that for patients, sometimes that's the only thing that lowers it. And I'm going to talk about the bempedoic acid. I only have one patient that is using that. It's not very common, but Rebata, he was allergic to this, but this is an oral medication. It's very well tolerated, usually. There shouldn't be any problems. And the inclisiran, it's more or less the same in terms of effects for PCSK9, but the injections are less because Rebata, you have to inject 1 week in alternate weeks, but inclisiran is in first day, the third month, and then every 6 months. So it's very convenient. And so the next medication that you choose should be guided by what is the gap in cholesterol that I have to lower. Somebody that already had a heart attack and they use endosovastatin of 40, which is the maximum dose, and their SLDL is on 150, you know that Setia is not going to do anything. It's going to just lower it to 120. And so you're still above the units that you're supposed to have. So when that patient comes in, I give them the ezetimibe because they're going to use it. They're going to need it, even if they have Rebata. So according to the amount that you're going to need, that is what you're going to prescribe. We need to take into account and consideration the cost. Unfortunately, the is not good and many people cannot buy it. It's not as accessible as it would like. And of course, the preference of the patient, sometimes here in our island, people prefer what they can pay for. I can't say, well, give me inclisiran instead of Repata because I want to inject less times, because approval is going to be very difficult. It is a limitation and we have to understand that. Right here, I am giving you a table of the medication comparison of what we expect to see as a low, as how it lowers with the different medications and what are the key adverse effects. Statins that are high intensity should lower LDL-C in 50% or more. It is the medication where we have the most strong outcome evidence of lowering of cardiovascular events. Key adverse effects is myalgia. I have patients that have had that situation, and most of them, after using it for several weeks, they tolerate the medication. There are very rare liver injury or rhabdo situations. And those patients, of course, we have to move them to Repata. This is real. I had a patient where the liver enzymes went really high, so we had to use another medication. It went up again. So obviously, this is a problem. Ezetimibe alone, it doesn't do much alone. But if you add a statin, even in a low dosage, it's going to work well. And that's the way I convince my patients to use statin. Sometimes we have the combination, and if they see that this is working and they think that the dosage is low, they feel more comfortable with the situation. PCSK9, as I mentioned, is Rebata. It's subcutaneous on alternate weeks. There's a lot of strong outcome evidence. This is one of the medications that has the most evidence of reduction in cardiovascular risk. I've had patients that are allergic to the medication. And the other thing that is very common, and it's not mentioned very often, is that, of course, it can be, there can be an allergic reaction in the area of the injection, but the first time that have injection, they feel like they're having a flu, and that is expected for the medication. If you start somebody in Repata, I always advise them and let them know that this could be happening. Somebody has an open microphone. We need to close a microphone. We need to, I cannot hear very well because of the microphone that's open. According to this, in the slide, the statin intensity, atorvastatin 40 to 80, rosuvastatin 20 to 40. We use it for high risk primary prevention. We have, if you want to have high risk primary prevention, you're going to offer high intensity, and we have hypercholesteremia that is severe. You have to give them this high intensity statin, and patients that already have cardiovascular events need the high intensity. The other moderate intensity are for intermediate risk that you're going to try to prevent. And most of the patients that are diabetic are going to be in this area. Of all of this, which I use a lot, I use rosuvastatin, because if I can go higher, I can use it. Pravastatin, if they have muscle pain, that's going to help them a lot and they can tolerate them. Pravastatin, if it's a one that is less associated with pain, pitavastatin, I don't use. There's a lot of interaction with other medications. You might be using simvastatin, but if there is an interaction with other medications, then you have to lower it. So I don't like changing from one statin to another, so I try to avoid that. And of course, you're going to try the patient with a dosage that is, the response is not the same in one patient from another. You have to personalize, and you have to start with what's indicated. If there's an event, you start with high intensity. If they lower the cholesterol and disappears from the system, maybe you can lower the dosage. And when you change medications or you start medications, you need to repeat the cholesterol 4 to 12 weeks in the lab to see how the patient is really doing. In terms of the statins, as we mentioned, the most common thing is muscle pain. They think that it's articulation pain, and we might check that it's arthritis. Maybe it's not a medication and it's arthritis. We can check the liver enzymes, and I always, when they start in statin, I always ask for a lab to verify the liver enzymes and to verify if there was any other symptom, if they are very high risk and we have to change something. Intensify is usually well tolerated. When you use with the other statin, you need to check the liver enzymes because they could go higher. And PCSK9, they have reactions in the injection site. Sometimes they are rare hypersensitivity cases. I've just had one, and you don't need to do any routine laboratory monitoring. You can tell them that they could have like flu-like symptoms. Bempedoic acid, we need to check the uric acid. And if you look at the lab and see of creatinine and bun rise, we need to be aware of that and be monitoring that. The other thing that's important about this bempedoic acid is that they could have tendon symptoms. And with bile acid sequestrants, you can have GI symptoms. Sometimes it's not well tolerated, and triglycerides that are very high, you shouldn't risk it because there's a risk for a pancreatic uh, disease. If they have fatty liver, that is not an indicator to stop the statin. That's part of the treatment of fatty liver patients. So that is another thing that we have to consider carefully. In terms of symptoms, you must know this table and must be handling this every single day, multiple times a day. The patients that are using statins are always complaining about this because, of course, there's a lot of misinformation in social media. If they talk about the symptoms, check the timing, check when the symptoms started, check when the medication started, how severe they are. If do they feel not only pain, but they feel weak? Maybe that is a real indication that there's a problem with the medication. Check thyroids, vitamin D, hepatic function. If the symptoms are, moderate, not severe at all, low, maybe we can handle the dosage, lower the dosage, maybe on alternate days. Sometimes I lower the dosage, but I give them acetabide. And if pain keeps showing up, we are going to do a recharge. We're going to use another statin sometimes. And this is my experience in the office. They use atorvastatin in very high dosage. And when you go to rosuvastatin and it's 20, which is the same as the other statin at 40, when they look at a lower dosage, they feel more comfortable, and that could give you an option of moving from one statin to the other. And if the patient is still above the goal that you have decided on, then we need to scale on the therapy according to what is needed in each stage. One of the things that I do with one of my patients, with the patients, and one of the things that we do in the office is we have a list of problems, and as part of that, I use hypercholesterolemia. I have the risk factors, my goal in LDL or non-HDL. What is my goal? I reevaluate in my next visit to see if I reach my goal. That is an easy way to verify if you are where you want to be. This is just for patients that have the LDL above 190 or more. They are going to need that medication. It doesn't matter if it has to do with the reproductive age, if they're less than 30 years. These people in this situation, they are going to be on the medication in high intensity because the risk is very, very high. We need to look for secondary causes, as I mentioned, other medication, such as Accutane for acne. Patients that have nephrotic syndrome, they have hyperglycemia that are very high. And the same thing with hypothyroidism. Sometimes they have 210 LDL and they have 9 in TSH. If you deal with the thyroid, you won't have the LDL problem. So you're going to start with the highest statin that they can handle. You're going to give them high intensity, and you're going to go down as well as you can. And we are going to establish a goal for this patient if they have LDL in 190 or more, but they don't have any other risk factor, no history in their family, they don't have any subclinical disease. Well, the goal is less. If you have family history is less than 70, if you have other additional risks, less than 70, if you have CAC score, definitely less than 70. And if you had any kind of event, or for example, if you found something in a CT scan, you're going to want to lower it to less than 55. If there is a patient that has high cholesterol of 190 or more, and you had a sonogram in their legs and there is disease there, you're going to be super aggressive with those type of patients. And we're going to add therapies according to what we need to be able to reach the goal that we have set. Patients with very high, severe cholesterol, high cholesterol might be a familiar situation from their family history, and you have to probably look for genetic tests. For patients that are diabetic, it doesn't matter whether LDL is, diabetes is the same as coronary disease, and you're going to treat them according to the established goals. They need that statin. When you have hypertriglyceridemia, there are two goals that are important. One is to diminish cardiovascular risk, and the other is diminution or prevention of pancreatitis. We're going to ask for lifestyle changes, eating behavior changes. We use statins to start with these people. If this patient has atherosclerotic disease and they have 350 or 150 or more in triglycerides, you're going to optimize LDL, and the medication that is recommended is Paceta. It's the only medication that lowers triglycerides that has shown a diminution in cardiovascular events. Niacin, fibrates, none of those medications lower the risk of cardiovascular events and are not recommended because first you have to provide the statin, and those medications, fibrate, niacin, they increase your risk. Prevention for pancreatitis, if they have 500 or more, people have to be in a very strict diet. There's a guide that shows what's a percentage of fat, sugar, and whatever else in terms of their triglyceride level. If they are 1,000 or more, they have to be very, very low fat diet. Sometimes they have to be hospitalized, a drip of insulin to be able to lower those triglycerides because the risk for pancreatitis is very real. You could consider giving them fibrate because obviously the risk is very high, and prescribe omega, uh, but omega-3 is Lobasa. This is the type of omega-3 that we're talking about because it's very, very powerful. We have to talk to the patients about what they're eating. And I always tell people fruits, vegetables, whole grains, legumes, nuts, fish, replace saturated fat with unsaturated fat, feta cheese, olive oil, virgin olive oil, avocado, etc. Weight, if we have obese or overweight patients, we have to look for a way of losing that weight. You have to exercise. It's not only aerobic exercise, but we have to do also resistance because this allows us to burn fat. We have to stop the smoking, total abstinence, and of course, there are no supplements that we can offer to lower LDL-C. The over-the-counter omega, there is no scientific evidence that they will lower the risk for a cardiovascular event, so that I cannot recommend it because there are very extensive studies that there's nothing happening. The call is stuff that people buy over the counter that doesn't lower cholesterol. They are going to visit you with the bottle of the medication, and you're going to say that's not it because it's not. And how are we going to follow up? We're going to see them, labs. You see that it's elevated. We check hepatic enzymes. We discuss risks versus benefits. We check the risk factor. We start with medication or we change therapy, and we reevaluate in 4 to 12 weeks. If we are there at the goal, we can see each other in a year. But if we haven't reached that, we need to continue working with more frequency to be able to reach that goal. Patient that does not reach the goal, ask, are you using medication? Are you using something else? We need to think that there's something additional that's going on. I have a list here of some of the things that could be red flags for consulting a specialist, a cardiologist, patients that have an LDL that is very extremely high, that you think that might have high cholesterol from their family history, you have to verify that. If they have very high triglycerides, of course, that's a problem. If they have events from atherosclerosis, even if they're in medications, you need to refer them. If they have LDL of 190 or more, I would refer them because most of these people need genetic testing. Lipoprotein that is very high should be referred because we need to stratify the cardiovascular risk for these people. And there are other conditions, pregnant women, other conditions, HIV, something like that, you should consider referring. And any patient where you don't feel comfortable, you think, I'm giving everything that I need to give this patient, but it's not improving, or I'm really worried and concerned about the risk over what I'm doing. Obviously, these are patients that you need to refer for getting more help. I have a case here for you to see if we can apply a little bit of what we have been discussing. She's a 50-year-old woman. This is so you can try to answer. 50-year-old woman. She has hypertension. She doesn't have diabetes or ISCVD. LDL-C is 156 mgd with 185 triglycerides. LPA is 165. So all of those numbers went into the calculator, and Prevent gave you a 10-year risk of 6.2. So what is the risk that you would classify this patient at? Is it low, borderline, intermediate? What is it? How would you classify this patient according to those numbers? You can use the chat or you can raise your hand so you can participate. It's intermediate, and we could even say high. What out of their family history do you think we can use to personalize the decisions for this patient? What additional things to the 6.2% that gives us that intermediate classification? Things that are concerning from what you see from the labs and the situation presented here. I think somebody LOS, but we don't know what we're talking about. We're checking the chat. LPA, correct. That is something that is a risk factor. And also the triglycerides that are very high or high. And just for this, I want to share with you, it's not documented here. She's 50 years old. She's a woman, and probably she's in the menopause. So definitely, this is another risk factor. And in their family history, we don't know if there was preeclampsia, if they had a baby at 36 weeks. That is additional risk factor. So maybe she's intermediate and maybe she's moving towards high. And how would you treat this patient based on this? We already said that it's intermediate, and we know that that means they're going to have statins. They're going to have medications. So it's a statin that is moderate in intensity. In fact, if in their family history, you know that there's a preeclampsia that shows up and maybe she's in the menopause and they tell you, oh, yeah, I've been in the menopause for like 10 years. Well, then you could consider there that she needs high intensity statin. Somebody wrote change of lifestyle first. In the previous guides, we would give the patient the chance for lifestyle changes, and then we would prescribe statin. But in the new guides, it's, you know what, we're going to lower this risk. If you change your lifestyle, I will lower your dosage, but you're going to start right out of the bat with statin. And what is the goal for cholesterol in this? LDL, how low do you want it? What's the number you're looking for? I like what Katia is saying. We should lower it to less than 100, but I would say, you know what, less than 70. That would be my goal. But according to the guide, it would be less than 100. And when I say that, I'm thinking that maybe you're more of a risk because 185 in triglycerides means that your sugar glucose levels are not controlled. And since it's an intermediate risk, if we are in doubt, if the patient is not knowing what they're going to do, if they're going to start it with a statin or not, what can you do? Exactly, Enrique. I am in agreement with you. Most of the patients don't want to have the statin. I feel that I waste most of my day convincing everyone, but I feel that it's a responsibility that they know that definitely risks versus benefits. You know, you need the statins. And I tell them exactly this. Most people have statins in their system, the people that I love, and I tell them to have the statin because I trust that it's safe. Muscle pain is overrated. And I will tell you that in addition to the studies for diabetes that I mentioned, that those that use placebo developed diabetes 3 months after the ones that were using the statins. We also have other studies on muscle pain, and the patients that were using placebo had the same amount or more of pain in their muscles than the ones that were using statins. And patients that were using statins, we would tell them that we were changing to placebo or they were going to discontinue, they would continue reporting pain. So the majority of the times it's not true. If the patient says no, it's important that you give them the scientific data because you can't make them take the statin, but you can give them the information. But if we are in doubt, us as doctors and clinicians, we are going to use the number that we need to see in the numbers that they provide from lab to reclassify the risk of the patient. Because if this patient has 450 number in the CAC, this patient definitely is not an intermediate risk, it's a high risk. And patients like the CAC scores because they understand that that means, yes, that they have their arteries all clogged. In terms of liver risks, because we follow up 4 to 12 weeks, I give them the medication and I tell them I'm going to see you between 4 to 12 weeks. Generally, every 8 weeks, I'm going to give you a lab and I'm going to give you a CMP to check your liver enzymes, and that's it. And if there are patients that are very problematic, I send them to get an abdominal sonogram. And if there is something weird, you know what? Because you have a fibrosis due to fatty liver, of course we have to check. But we have the follow-up for 12 weeks. So 5 important points that we have to take with us. We have to measure the lipoprotein at least once in a life. We don't use the pooled cohort education. We use prevent.
Sometimes that's the easier to learn the LDL and the reduction the percentage reduction, we are going to use the CAC score when we are a little bit uncertain about what is the decision that we need to make for the management of our patients, and we're going to continue escalating therapy as needed. If you feel uncertain, if the patient is not tolerating the therapy, then the patient. I'm sorry? Moraima, would you like to ask any questions or comments? Okay, then I am available to answer any questions or concerns. Yes, Dr. Colon, because we are running out of time, we are going to ask the patients to forward their questions via email, and then what I'm going to do is that I am going to go ahead with the survey, and while they fill out the survey, yes, you may go answering the questions there. Yes. On the chat, you have the link for the survey. So we may continue with these webinars. We have a survey. We appreciate uh, that you have stayed. It is already uh, after 4. Thank you for your interest and for staying with us. So this will be the last. And tomorrow we are going to have Dr. Colon again with us. So if you have not registered for that webinar, go ahead and register because we come back tomorrow at the same time from 3 to 4. It was a pleasure. Thank you to all of you. Thank you to Dr. Colon for joining us today. And I apologize for the delay. I had some technical issues with my computer. I apologize. Doctor, and is there a way to have this presentation available? Yes. In fact, what I can do is that I can forward you, or maybe you can forward it to them on a PDF format. Yes, we upload our presentation to the digital library. And in that link that Julio is posting on the chat box, uh, we're inviting you to visit our digital library. And after this session, then tomorrow, it is already going to be available for you. And tomorrow's session, then we will have the presentation after the session. I generally use a program and I make notes. Yes, after the presentation, yes. Okay, no problem. Thank you. Sure. And if they are asking about the link for tomorrow, yes, we are going to forward you the link. It's not working. Well, if it's not working, that link, we apologize for the inconvenience. And on the polls, if you click polls, you may see the survey, and I think that the QR code should be working as well. And we are going to be emailing to you those links that you are asking about, so everyone can have them available. I am going to post here my email address, so you may have my contact information. This is my email address, so you can email me. Exactly. ccolon at sanpatricioheart.com. I apologize that I use caps, but I don't mean to yell or scream. I am going to post another QR code. You can use it on your cell phone because I think that because of the technical issues, we have not received any response to the poll. Julio inserted the link and you can use it now. And please let us know if it worked for you. Yes, I think that some people are already using the link. Thank you to all of you for your patience and for joining us today. The the guidelines have more than 125 pages, so it is very dense. I try to simplify it as much as possible, and there are many additional things that are very interesting in the guidelines, but I didn't want to overwhelm you with that. So definitely, they made really good changes, in my opinion. These are good changes in the guidelines. Okay, thank you to all of you. See you tomorrow with Dr. Colon. Thank you so much for your presentation and see you very soon. It was my pleasure. Thank you very much.